and the first topic was wireless halter. And just I want to add two things about wireless halter. So, do you know what is the most important uses of wireless halter? Two indications. Number one is detection of paroxysmal AFib in stroke patients, ischemic stroke patients, and second thing is the detection of sudden cardiac death in post-MI patients. And why these wireless halter are useful? Because they don't require change of device every time, like 24-hour halter. That's why these devices are my favorite. And this is the age of nanotechnology. And leadless pacemaker is just a continuum. So this is the history of pacemaker, and if you see this, first there was an external pulse generator, and which is attached to AC circuit. Then comes the external pulse generator, which is attached with a battery. Then in 1958, there was first invention of an implantable pacemaker device. Then nearly after 20 or 30 years, there is development of nowadays the pacemaker model. And now, from 2016 onwards, there is marketing of leadless pacemaker. So the journey has begun from the external pulse generator, now it is leadless pacemaker. And in next 20 minutes, I will discuss why it is gradually becoming the standard of care. Initially, when we are using leadless pacemaker, the indication was sick sinus syndrome, but gradually nowadays it is useful even for AV blocks. Okay. So, leadless pacemaker is basically a small implantable device that sends electrical pulses to the heart when heartbeat is too slow. What is the advantage? First, less invasive, less implantation time. I must say, the implantation time is less than conventional pacemaker. Less recovery time. The very next day, patient can be discharged, even on the same day also. Eliminates complications related to transvenous leads like venous obstruction, insulation leg, lead dislodgement. So one of the most important complication of normal pacemaker is probably lead related complication. That means TR, tricuspid regurgitation, and tricuspid regurgitation or tricuspid insufficiency is such a thing when it develops, then it gradually deteriorates right heart. And unless and until it becomes severe, you will not notice that patient. And when you will notice that patient, you will have no option. Then, probably infecting endocarditis. And another one is probably venous obstruction. There is visible lump, lead-related infections, PG-related infections, pocket hematoma, pneumothorax, less radiation, and better quality of life. So often the patients who are having normal pacemaker are often having TR, often having pocket infection. That's why the leadless pacemaker has come to market. So the first indication was the patients in which you can't go for conventional pacemaker, where the chance of infection is very high, the erosion, pocket erosion is very high in those patients, CKD patients. So that's why leadless pacemaker has come. So this is the basic model. There is this one is the guiding catheter. One is the pusher catheter, and this is the miniature pacemaker, and D is the steering arm. So this is the basic model. This is the basic model of both the leadless pacemaker. Central has come with leadless pacemaker model initially, which is known as nanostim. And then Medtronic, the St. Jude's has active fixation screw, the nanostim model, and Micra has tines. So gradually Medtronic product has superseded the market. Now, just last year, Supratip has come up with the modification of that nanostim model, which is known as Avian. So, what's needed? What's needed for leadless pacemaker? Number one, catheter-based device system, high density energy source, low power electronics, mobile communication system. I am not going into the details. So, basically, leadless pacemaker is like a capsule. So these are the picture of leadless pacemaker. This is the nanostim model. This is the micra. Micra, here you can see the tiles. And this is the weak EBR model, but this is outdated. So the modification of nanostim is in market, which is known as EBR, and this is micra. So it comes in December 2013, and this is December 2012. So initially by Supratip, then by Medtronic. So I am not going into the comparison, but one thing I must say that the micra device is smaller. Okay, and nanostim devices with larger device or with longer device, and it has active helix or fixation sutures. So this is a comparison. Just I want to emphasize one thing, that pacing mode is VVIR, and in both these things, pacing mode is VVIR. That means pacemaker can accelerate when it is needed. But in India, presently, it is mostly single chip. This is the comparison of these two devices. This is micra and this is nanostim. Nanostim device is longer. Just one thing I like to highlight here. Now, see this one. Fluoroscopy duration. It is only 8.9 plus minus 16.6. That means even it takes longer time, it only takes around 30 minutes. So that is less than a conventional pacemaker. So when we do conventional pacemaker, we need to take out the vein, or we need to do 2 PLI. After that, we need to implant 2 leads. So that at least takes 35 to 40 minutes. But here you can see sometimes procedure time is as short as 9 minutes. Even with nanostim, the procedure time is as short as 13 minutes. So it is fairly uncomplicated procedure. And here you can see another thing. Now, final device position. In case of micra versus nanostim, in micra most of the devices are implanted in the apex. And here you can see the successful implantation is 99.3%. So almost all the cases are successful. Almost all the cases are successful. And most of the time devices are implanted on the apex. Main procedure duration is 34.8 plus minus 24. So main procedure duration means it is included with patient transition time. But the fluoroscopy time is significantly less. And if you see the major complication, it is 4% versus 6.5%. It is not that high. And there is no significant device dislodgement in case of micra and also nanostim. There is chance of lead dislodgement in case of conventional pacemaker. So my main aim is to establish that leadless pacemaker is not that much complicated. It is only cost issue. Probably it is a sophisticated device with higher cost, but it is not at all complicated. Complication rate is not that high. So This is the implantation system. Here you can see the introducer and dilator. It is 14 French dilator. 14 French venous access, not even arterial access. That one is best thing. The chance of hematoma is less because venous system is always accommodative. And this is the basic pacemaker delivery system. Here you can see there is one locking button, and with this you can steer the catheter, and on the head there is the actual device. This is the actual leadless pacemaker. Now I will show one video. So this is the procedure. Just initially I show these few pictures, then I will show the video. First puncture, then they navigate through the femoral vein, then they navigate the tricuspid valve. This is the protective sheath, then they take out the protective sheath, the pacemaker comes out. This is the leadless pacemaker. They ensure the position in LO and RO view, and then they cut the string to just deliver this. And then there is absolute no follow-up needed. Only thing, when they are satisfied with position, they cut the string and the pacemaker takes its own position. This is seen in fluoro. This is the position of the pacemaker. Now, just see this video. This is the video of leadless pacemaker. First, the introduction of the delivery sheath. The delivery sheath navigates through the femoral vein, and then it reaches up to the mid-right atrium. Then we take the dilator and we introduce the actual catheter with protective sheath. Just with small cord, we navigate it like a temporary pacemaker. It is just a larger version of temporary pacemaker. Then we ensure the positions by giving dye to the catheter, and then we pull the protective sheath. This is the pulling of protective sheath, and here there is the thread and pull and hold tape. Now this is the actual movement you need to see. This is the actual movement. And if you are not satisfied with the position, you can recapture and reposition the device. Recapture and reposition the device again. Then, if you are satisfied with your position after next deploying, just cut it like this, and then pull the thread. This is just a 30 minutes procedure. And the device takes its position. So this is the same animation. This is the sheath. This is the guiding sheath. Then it is the LCP, leadless cardiac pacemaker, with the protective sheath. You deliver it, then you pull the protective sheath. You are satisfied with your position. You are satisfied with your threshold. Then you just take it and cut the wire, cut the thread, and it will take its own position. So next thing, we need to know what are the contraindications. So if you have ICD and CRT or any neurostimulator, you can't go for leadless pacemaker. If you have unstable angina pectoris or recent MI, you can't go because cardiac perforation is a complication. If you have mechanical tricuspid valve, you can't go for it. If you have implanted vena cava filter, you can't go for it. Left ventricular assist device, you can't go for it. Morbidly obese patient, you can't go for it. difficulty in elementary programmer, and if they are intolerant to titanium or nickel titanium, or if they are unable to tolerate emergency sternotomy, or limited or missing femoral venous access stenosis. These are the contraindications. So this is the device, actually micro device. This is the. Now there are two trials. These trials are with mainly nanostim device, but just I want to highlight few things. Now see, these trials are to see safety and efficacy. Now see, implant success rate was 97%. One patient only out of 32 developed RV perforation and cardiac tamponade during implant procedure. So one patient out of 32. So that is not a significant number. These trials are to see whether there is safety or efficacy or not. Next is the chronic performance. Chronic, if you see the chronic performance remains same at the age of 1 year. Now, here I want to show one thing. Now, most of the pacemakers are deployed on the first attempt, that is 23. Okay, median implant procedure duration was 24 minutes. Now, this is an important slide which shows that safety and efficacy of that pacemaker is same at 1 year. Now, this is the pacing threshold. Pacing threshold has been decreased. This is RF amplitude. RF amplitude has been increased, and impedance has decreased. So, it is fairly safe. You need not to worry about it. So, this is another leadless trial. So, these are basically continuum of the same trial, and this shows also safety and efficacy of this pacemaker. And just I want to show one thing. Now see that the cardiac perforation event rate was 1.5, vascular complication was 1.1, device displacement was 1.1, and pacing threshold remains same. So, in conclusion, it is fairly effective, threshold remains stable, and procedure time is significantly low, and it is safe device for those patients whom you are very concerned about infection. Thank you.
There is beautiful presentation of the case. I must request the failure rate.
Failure rate is not that high. 99% pacemakers are implanted successfully. And the device dislodgement rate is also which is small. Slightly 1% that is similar. So if you have failure, then you can deploy second mitral. So that is also an option.
What is the cost?
Only thing is the cost issue. But probably in near future, when we will use it more, probably the cost will decrease. So initial cost is probably due to R&D purpose.
Any question?
13 lakhs.
I would like to ask one question. Limitations regarding lumpectomy. Limitation means it is single chamber pacemaker. In dual chamber pacemaker we can use it. Regarding the perforation and within the implication of this one, implanting this pacemaker, we do find chances of perforation, and as well as if I want to change it after 15 years time of period, and because you know very well, time period is more or less 50 maximum period is 15 years. After 15 years, if I want to change, or I want to change it is not possible to replace every one. So if I change one head, maybe the one was big implant, the field that is there. How many of the implants, pacemaker implant? And finally, I would like to say that because there is a complication also it is seen many times regarding battery of this one when we return with the other cases. So what is your opinion regarding our cost regarding changing, replacement and limitations of the single chamber pacing or the dual chamber pacing.
Regarding cost is on bit on the higher side. So if you want to change this pacemaker, you can recapture with snare, either with single loop snare or double loop snare, or you can keep that initial micro pacemaker on that side and you can put second pacemaker. But overall compliance of the patient is good as per our experience. There is a risk of cardiac perforation and that risk is real. So you have to be cautious. Probably cardiac perforation is the only risk, but the complication is not that high. Actually, in leadless 2, there are 3 patients who developed cardiac perforation, and in leadless 1 patient developed cardiac perforation. But in leadless 3, out of 3 cardiac perforations, only 1 patient developed pericardial tamponade and required pericardiocentesis. But the other 2 patients doesn't require anything, only conservative management will suffice. And for changing of battery, I have already mentioned, either you can recapture the pacemaker with snare and then you can take it out, or it is better to leave the pacemaker in the same place, because often there is encapsulation just like the lead. So it is not prudent to take the pacemaker after 15 years, because often we keep the leads in the same place which are to be replaced.
So how often do you recommend taking out the battery?
Yes. AV synchrony is not maintained. So initially we use in those patients who require rescue pacing. That means, suppose a sick sinus syndrome, patient occasionally had dizziness. So initially that was the indication. But nowadays the pacemaker model of this leadless pacemaker is coming with VDD pacemaker. That means they can sense atria. So when they sense atria, they will do AV synchronized pacing. So the gradually models are coming. So this is actually in the pipeline. This is actually in the pipeline, and probably this will be the future.
Sir, how often do you recommend taking out the battery? Is it the same as that of a conventional pacemaker?
No, generally it takes around 15 years. In conventional pacemaker, it is around 7 to 8 years. Often there is early drainage of battery if there is higher threshold of leads. But generally, in case of leadless pacemaker, at least battery goes up to 15 years.
Thank you, Dr. Kundu, for your brilliant presentation.
Anybody else?
Thank you very much. So,